Siyabulisa kubabukeli bethu bonke, head to toe with Dr. T. We're talking health from head to toe. Abantu basazi ngodibanisa impempe negusheshe kutaka umntana. But abantwana bataka benezinto ngezinto. We've got what we call congenital heart problems. Now I'm bringing you a guru, someone who's educated, a fundi in the field of pediatric cardiology. Dr. Jiyana. Sam, can you greet our viewers, please?
Good morning to the viewers and good morning to the, it's actually evening now, at 9 p.m. Good evening to the listeners and good evening to the community at large.
Thank you, Sam, and thank you for accepting our invite to Head to Toe with Dr. T. Let me just do a brief introduction. Sam studied in King Williamstown. That is where he was born and bred. King Williamstown, these days, which is not far from East London. So he's an East Londoner. Wafunda at Dale College, which is a boys' school. Then from there, he obtained his MBCHB, that is Bachelor of Medicine and Bachelor of Surgery degree, pa Walter Sisulu University. I'm sure we can also say WSU. Definitely. We studied while it was still University of Transkei. We thought we were the Republic then.
Yes.
And then after finishing his MPCHB, he's a diligent guy. He went on to specialize in pediatrics, Ugqirha Wembambino, specialist Sabantwana. And then he never stopped. That's the nice thing about academics. Once they start doing one thing leads to another. After finishing pediatrics in the East London complex of hospitals, that is Frere Cecilia, and then including the hospital in Cape Town.
Red
also
Cross.
Had Red Cross Hospital in Cape Town. So you were a traveler.
Yes, I was a nomad.
Thank you so much. Then immediately after finishing pediatrics, he went on to register as a fellow of the College of Pediatricians in cardiology. That is, he went further just to focus on the small heart of a baby. So today, he's a fellow of the College of Pediatric Cardiologists. That is a certificate. Thank you so much. You're doing us very, very proud as a country. And one thing that made me proud is that he is involved in two prominent studies. The PE arm of these studies, he's actually heading them. The ADOL 7C study, which is heading in PE, and the IMOTEP study is also heading the PE arm of that study. If you know studies, you can't do research without spending more time on studies. So he's into research and producing papers. I'm so proud of you, Sam.
Thank you so
for
much.
representing us, and welcome to Head to Toe with Dr. T. I see you've got a big heart.
Yeah,
Can you
thank
educate us?
Yeah, I bought this hat since your guests always have something to talk about physically. Firstly, with us, it's always people actually get surprised to even hear that children have got heart problems. When you say you are a children's heart specialist, people get surprised that children do even have heart problems. So yeah, we do exist because 1 in 100 children are going to be born with a heart condition. So
1 in 100
in
children.
100 children.
It means this is very common, actually.
It's very, very common. And not only that, but if a child is going to be born with anything abnormal, it's going to be the heart. Okay. So this is our heart. So the heart consists of a left side and the right side. This is the right side of the heart, where blood comes into the right atrium, goes into the right ventricle, and is pumped out to the pulmonary arteries. That would be to the right and the left pulmonary arteries to get oxygen. It then returns to the left side of the heart carrying oxygen, and then goes to the left atrium to the left ventricle, and is then pumped out. It's then pumped out of the left ventricle into the aorta and out to the head and the rest of the body. So when we speak about congenital heart...
Just before you fly, Sam, I'm thinking of a life sciences student. This is the moment that people pray for, to have such a serious academic carrying a heart at hand and showing us how actually the dirty blood, that is deoxygenated blood, flows and then the oxygenated blood flows, and how actually, because you are going to educate us about a blue baby.
Yes.
We're talking about a baby born blue because of heart problems. And fortunately, Dr. Jiyana is doing work in the private sector at Truncus Hospital and also assisting the public sector.
Yes.
Thank you so much for that. We've got the left side of the heart, which is dealing with clean blood, oxygenated blood,
Yeah.
and the right side, which is dealing with blood that is tired.
Yes.
Thank you.
So that is deoxygenated or blood which doesn't have oxygen. So what can go wrong? So you can get problems with blood getting to the lungs. Okay, so where you have a decreased blood supply coming to the lungs. So where can the problem be? So the problem firstly can be in this valve, the tricuspid valve, where the valve, so we're not talking to doctors, we're talking
Yeah,
to the
we're
general
talking to-
the
yes.
general public. So the right-sided valve then closes off, then blood cannot get to the lungs to get oxygenated. Okay, so that's where the first problem may be. The second problem,
So that can lead to a blue baby.
a blue baby. Second problem, there may be a problem where this valve that's supposed to take blood from the right ventricle, take it to the pulmonary artery and take it to the lungs to get oxygen. Also, the baby may be born and that valve is closed off. What we say is pulmonary atresia.
Okay.
So that's the conditions of decreased blood supply. So where you get a blue baby, in this case, you find that the baby is immediately blue when they are born, and it's noticeable. And often those children will be referred to hospital, and the referring hospital to a higher center where they can be managed, because usually they do need an intervention, whether or not medication to keep, there is a blood vessel that the child has when they are born, which is normally supposed to close, which is called a PDA. But in a child who's got a condition where there's decreased blood supply to the lungs, then that patent ductus arteriosus, which is supposed to close, actually then keeps the blood going to the lungs until this problem can be sorted. But it is not a reliable thing because it's meant to close. So therefore, we need to do an intervention, either give medication to keep it open until the child can go to theater, where a surgeon then will put in a shunt, and a shunt is now, he will make an artificial connection from one of the blood vessels coming to the aorta to take blood directly to the pulmonary arteries where there isn't a way to go there. Okay, so those are the.
So you said, Dr. Jiyana, sometimes we can immediately pick that the baby is blue at birth, and at times, so it means there are times that a baby can be born looking pink and then may
Yes.
turn blue as time goes around.
Exactly.
Good evening and welcome back. We've got Dr. Sam Jiyana, who's a pediatric cardiologist working at Truncus Hospital and also doing sessions at the public hospitals in PE, mainly Provincial Hospital and Dorangenza Hospital. Thank you very much, Sam, and thank you for the lessons. Okay, you're talking blue baby. Can you carry on?
Okay. And then another condition which is more common, and which we'll probably talk about in the next segment, is when you've got tetralogy of Fallot, where there's four lesions involved in the heart. Mainly, there's an obstruction, again, in the pulmonary valve taking blood to the lungs. And because of this has happened whilst the baby was inside the uterus. So because of that, the right side of the heart becomes hypertrophied, so which is the second lesion. And then there is a hole. So you see that there's no connection normally between the right side of the heart and the left side of the heart. In these children, there's a hole between the right side and the left side, what we call a ventriculoseptal defect, which is the third lesion.
Okay.
And the fourth lesion is that the aorta only gets blood, is normally committed to the left side of the heart. But in tetralogy of Fallot, the aorta is sort of like in the middle, so it's getting blood from the right side, it's getting blood from the left side. Hence, that child will be blue. So, but it may be that sometimes that child may appear pink because the degree of obstruction of blood getting to the lungs is not that much. But it can be that, it can be severely blue when there's a severe obstruction. And it can be completely closed and there still be a hole in that side of the lungs. So these children, especially those with tetralogy, someone will say, no, this was not picked up early because then the child was not at that time blue. But we'll talk about it in the next session and what happens. So we may also get conditions whereby there's increased mixing of bloods, but the child is blue. There's mixing of blood, but the child is blue. So in that case, the aorta and the pulmonary artery may be mixed around. So in this case, the blood that's deoxygenated is going to the rest of the rest of the body. And then the blood that is oxygenated comes back, it goes to the lungs, but still comes back to the lungs. So therefore, the two systems are running parallel, but not talking to each other. So the rest of the body is getting deoxygenated blood. So that needs an intervention quite early as well. You may also get a condition where some children, because you remember in medical school we speak about embryology, that's the formation of the body. So the body, when the heart is formed inside when the baby is being formed, this is normally one big trunk. So the development of the heart can arrest at that stage, and you get one big trunk where you get mixing of that blood, what we could talk about as Truncus Arteriosus. So you may also get...
So we've got ductus arteriosus, then we've got Truncus Arteriosus, all leading to a blue baby.
A blue baby. But the ductus arteriosus normally doesn't cause on its own the baby to be blue, but it is part of the conditions which the baby is pink. So, and then the other last one can be a problem whereby the pulmonary arteries, instead of coming back to the heart to get oxygen, bring in the oxygenated blood, they come back to the right side. So it's either some of them or all of them. So and then the right side is not used to that circulation. So then what happens is that the child presents blue and in failure. Okay, so, but here we're not talking to doctors in this talk, I'm saying it again. So we're talking to the general public. So how will the mother know if your child, if the child has got a blue of those conditions? Firstly, the sisters may pick it up within the clinic from the hands and the feet becoming blue. Another one may say, but no, maybe the child is cold. What if it's not this? Maybe the child is just cold. But the sisters know to check for oxygen saturations, especially now with the time of COVID. Everyone knows when you talk about oxygen saturation. So the sisters know up to what level to check for the oxygen saturation when the child is born, and they will refer appropriately at least within the first 24 hours, which is why I'm a big advocate for birth in a health facility rather than birthing at home. So these things are picked up early. For us as cardiologists, the sooner you pick up, the better, because that's the one challenge which within South Africa is the presentation of children with heart conditions. They often present very late.
Is it possible that someone can go on with this condition until they become adults?
They can go on until it is possible to go on and become a child at school-going age with some of these conditions, especially things like tetralogy of Fallot, where a child will be blue, 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 and people will say, no, he looks like the grandfather's side of the family, and not realize that this is actually, there's something wrong until they go to the doctor and the doctor hears, there's an abnormal heart sound. So, but how will you know as a parent? Firstly, you may notice that your child is blue. The child may not, as a newborn baby, the baby may not grow according to what other children are growing at. The baby may actually tire very easily or sweat when they are feeding or when they are breastfeeding. And even when your child starts school-going age, you notice that this child is more scrawnier and smaller than the other kids. Or if he plays, and then he sits down. It's because he's now struggling to get oxygen into his lungs. So But we'll talk about that when we talk about tetralogy. So those are the things that you may see.
You've actually spelled the symptoms very well. Ugqirha uthi in summary, ingxaki ezinobangela umntana abe blow okanye abe luhlaza zisenokwenzeka into yoba zivele esazalwa. Ngexesha esanduzalwa ukhawuleze ubone uba lo mntana ublow ngojonga nje intupha ezeminwe okanye ngojonga imilebe le, amanesi anakwazi ukuyibona loo nto okanye ugqirha. Okanye unongabonwa immediately, kuxhomekeka into yoba kuphithene ibhobhile phi apha entliziyweni. Ngoba sijonge ezinto zokuzalwa kwabantwana eze bajike babe blow ngenxa yezinto ezenzeka apha entliziyweni. Uthi ke zinokwenzeka apha edongeni lentliziyo, apha kwii-chambers, kumagumbi lawo entliziyo, okanye zinokwenzeka kwimithambo le ithatha igazi entliziyweni elisemzimbeni okanye elisemiphungeni, okanye le ibuyisa igazi emiphungeni. Sizawuthatha nje ikhefu umzuzwana, xa sibuya siphinde sijonge into yoba oogqirha ababakhulu kangaka i-pediatric cardiologists bayibona njani yonke le nto, and then yintoni enokwenziwa xa kufumaniseka into yoba lo mntana unezinto. How do they pick up all these things? Ingaba sinawo amandla okunyanga ezi zinto kubantwana bonke, and abazali baxelelwe into yoba funeka benze ntoni na kukuqaphela umntana uba usenongatyi kakuhle okanye ibelanga lincanci, akhawuleze udinwa kayidlala okanye afune uphumla, okanye ubone xa umthelekisa neentanga zakhe uthande ukunqaphela, akakhule ngale ndlela ukulindeleke ngayo. Enkosi kakhulu. For now, we'll be back shortly. Thank you. Welcome back to Head to Toe with Dr. T. We're talking the blue baby, umntana oblow, with Dr. Sam Jiyana, is our pediatric cardiologist. Gugqirha ke omkhulu lowo o ingcaphephe yabantwana. Akapheleli uba ingcaphephe yabantwana, wahambela izifundo zentliziyo, is a certified pediatric cardiologist, a fellow of the College of Pediatric Cardiologists. Sam, ngumuntu omkhulu, but thank you for gracing us. Thank you so much. How do you guys get to see all this in such tiny babies?
Sekumandi, it's sekumandi ngelo xesha because there's a lot more awareness even within the general practitioner community about children with heart conditions. So the doctors pick it up that they may hear an abnormal sound, or they notice that the child is blue. And in some children who present early, their hands may develop what we say clubbing, where the fingers look more like suckers, yeah, or swollen a bit. So then they refer the children to us. They would have done a chest X-ray, perhaps even a EKG or a ECG to check shumbane wentliziyo, to look at the electrical activity of the heart, which may point you towards the right lesion. Tina, we have equipment that is specialized, such as an echocardiogram, where we put a probe in your heart on top of your chest, and we generate images.
Is that an operation or what?
No.
There was a
No. So sizawuqala we do an echocardiogram, which is a non-invasive test, where we put a probe on the chest. Sibone pha uba kwenzeka ntoni entliziyweni yakhe ngaphakathi engakhange aqaqe. Of course inazo ii-challenges zayo because kaloku iphezu kwesifuba, kukho inyama, kukho amathambo, then ibe yimiphunga, then ibe yintliziyo. But ngokoomatshini kwangoku we see a lot of more better images than we used to see before.
Okay.
So that's just one part of it. I would say, I always explain it to my parents, to the parents of the children, that the echocardiogram is like looking through the window inside the heart.
Okay.
We take the child to cath lab to gather more information now. So in cath lab, we wear special equipment, then we look like aliens. And there's big machines in cath lab, big x-rays that we use to look inside the heart of the child, and we use catheters to inject dye and see how the lesion is, to measure the pressure in the lungs, to measure how big the hole is, so that when we gather all this information, we give that information to the surgeon, so that the surgeon cannot go to theater and open the child's heart and find, kunjena kanti. So he only needs all
So
that
you work
information
closer with the
with the
surgeons.
heart surgeon, yes. So the heart surgeon needs all our information to decide why, and we decide with him what kind of operation this child must have. There are now, with the advancement of technology, there is not so much for the blue babies, but even for them, we use a cath lab to do interventions that we can do percutaneously without opening the chest, using the cath lab equipment to guide us inside the body and opening up whatever obstruction may be. If there's an obstruction in the pulmonary artery, if we see that there's a little bit of dye that can go through, we can thread a wire in there and open up the pulmonary artery with a stent, relieving the obstruction. And not only that, but buying the child more time before they get to surgery. Because sometimes you may find that the child is quite small still for surgery, and the surgeon may be comfortable doing it at a better weight. So we are able to do a lot of things in cath lab, and for example, to close the conditions where the child is not blue, for example, like a patent Truncus Arteriosus, we are able to manage that in cath lab and close it, and the child never sees a surgeon. And compared to having 2 weeks of post-operative recovery, the child may go home the following day.
Oh, that saves a lot of not only pain, but also in terms of costs.
Yes, it does.
Because to save the child from seeing a surgeon, and also the number of days in hospital, you say it can be reduced to close to 1.
Yes,
that's very powerful.
So back to the blue baby, some conditions may necessitate immediate surgery. For example, when the arteries are switched around, then we need to remember it's 2 parallel circuits. So there's a problem there, the 2 parallel circuits, in that the body cannot survive with deoxygenated blood only, like blood that is dirty, which doesn't have oxygen. So then we may have, if there's no hole here, then we may have to go to cath lab and make a hole ourselves until the child goes to surgery, so that there is at least some mixing happening between the oxygenated and the deoxygenated blood. So that, and then there was an operation to switch them back together. Or then there's some lesions where we decide, this right side of the heart is too small for us to do a full correction. Therefore, we need to do firstly the shunt, and therefore another shunt again, so 3 operations, and then lastly bypass the whole right side of the heart so that blood goes directly to the lungs. So the blood is joined from the top of the body, from this blood vessel down to the lungs, and then the blood from returning to the body is joined to the lungs as well. So the lungs, so then you get 2 different systems, but at least we say now the right ventricle is doing most of the work.
Okay.
Yeah.
Dr. Sam, in terms of, I'm looking at parents. Sometimes we blame ourselves for whatever happens, because this is a mother's egg and a husband's sperm. Is there anything that we're doing in terms of risk factors as parents to propel some of these
This is a very good question, because a lot of mothers think that, what did I do wrong? What did I eat? What could I have done? It's not really, as I said, it's the most common thing that can go wrong when a child is born. It's not anything that they could have done. Okay. That they could have done to cause these abnormalities to occur. There are certain conditions which are associated with more higher risk of cardiac problems. For example, if we speak about a child having isifosofuzo, such as Down syndrome, or having George syndrome, those type of syndromes where your doctor or your pediatrician will pick them up and look for the heart problems. And there are certain medications that are associated with causing heart problems, like medication for epilepsy or medication for diabetes. But your gynae normally changes these medications when the mother is pregnant. And another important thing is alcohol is very much, if a mother is drinking alcohol whilst she is pregnant, she's more likely to have a child with fetal alcohol syndrome, which we see very commonly in South Africa, and which can and is associated with heart problems.
Thank you so much, Dr. Sam. This is Head to Toe with Dr. T. Let's leave it there for tonight. Please follow us on Facebook as Aphile Communications and YouTube, Aphile Communications. Thank you so much for being with us.